It's with great pleasure that I welcome you all to this in-person and virtual meeting titled Data Collection Registry Clinical Trial Site Standardization Program, being hosted at the University of Maiduguri Teaching Hospital. My name is Dr. Adam Saladu. I'm a consultant hematologist. I'm going to be anchoring this program along with my colleague, Dr. Nkama. We're really honored to have a distinguished gathering of professionals, stakeholders. Sickle cell disease is an important topic to all of us, especially knowing that Nigeria has the highest burden of sickle cell disease. But also important, we know that as clinicians, sickle cell disease is a multidisciplinary condition. It's an inherited condition. It's a lifelong condition. So what it means, while planning for this event, we needed to have a holistic approach. We wanted the event to be all-inclusive. So today's event is a testament to the power of collaboration. And we're organizing this event along with the Global Action Network for Sickle Cell and Other Inherited Disorder, known as GANSID, in partnership with Sickle Cell Disease Research Group, both from the UMTH. We have participants from State Specialist Hospital, from Mama Shehu Memorial Hospital. We also have academics amongst us from pharmacology, physiology, biomedical laboratory. We also have members from the grassroots. I'm particularly delighted to have representatives from various primary healthcare centers. There's a saying that says, nothing for us without us. I want to especially acknowledge the presence of the sickle cell patient themselves and the organization. Shouting out to you over there. So I want to kickstart this event by inviting the CMD, Professor Ahmed Ahijo, to come and welcome us and open this event for us. Sir.
Sickle cell is mainly our own problem. It's our problem. We should manage our problem. We should look for solutions to solve our problems. As usual, our attitude, we try to shift responsibility. In doing so, if it has been shifted to the people, we blame them again. We get it that is primarily our responsibility. So please, when we say take up to your responsibility, contribute to development one way or the other. There is nothing like I'm a junior staff, I'm a cleaner, I'm a programmer, I am not the head of department, I'm not the CMD, I'm not the commissioner, I'm not the director, I don't have money. If you see all these statements, it means there is no ownership. There is no ownership. All of us in our lifetimes, there are many times if we don't have things, we go out to look for them. Nobody says in Ireland is having everything of his own. But if you lack something, sit down, think, plan. How do I get it? And once you have that plan, you map out option 1, option 2, option 3, and you follow them. It's exactly the same model. If you do not have any link to sickle cell, nobody will invite you here. So that means you have a role to play as an individual, and you owe your own society some level of responsibility by building a system that everybody will be proud of, by managing a system that everybody will be proud of. So please, one of the things why I say the meeting came in line with our own vision and mission is we also want to establish a center that manages sickle cell disease for Nigeria. So let's all strive to see that we build systems in our own environment that humanity will benefit. I would be the happiest person if we can build a center for other countries to come and obtain treatment here. I would be the happiest person. And not only building it, but sustaining it, promoting it, making it a global competitor. So please, this kind of training, we are going to do many videos for the surrounding and the clients will repeat it. But let us continue having meetings for the sit down and discuss issues that pertain incidents, then we plan how to overcome the challenges for the benefits of our own people that suffer from this disease. So, I once again thank you. I, on the behalf of the management of the University of Maiduguri Teaching Hospital, we will do everything that is possible to ensure that we succeed in establishing a sustainable center that can compete with any other center globally. That is the dream that we have. Utilization of knowledge is far, far, far more important. So please acquire and utilize 100% of the knowledge that you have learned here today, subsequent days of this event. Thank you. Thank you. I will give you a conclusion of.
So the first presentation is going to be delivered by Professor Ambi.
Good morning, everyone. Well, just to give a little experience of here, sickle cell disorder. Sometimes I want to say sickle cell disease or sickle cell warrior. Because now most of the people they stigmatize. It's a sickle cell disease or sickle cell disorder. So we say sickle cell warrior. That's one of our experience. I'm happy to have some of them that are here with us. And I'm also happy to have the primary health care from some of the local governments. Because this is an awareness that we want to build so that we will be able to reach to the community, down to the grassroots. Sickle cell will be seen that it starts from the age of 3 months. Some will just be coming with illnesses. You'll be saying, why is this child coming in and out of illnesses? We've been seeing some of them. Can we have next slide? So we did some retrospective studies, and we found out that yes, most of the diagnosis is from the age of 6 months to 11 months of life. The common presentation, hand and foot swelling, followed by jaundice, anemia, and vaso-occlusive crisis, we see more the ages of 1 to 5. And this is where morbidity and mortality is so high. What we are doing now, new cases of sickle cell, any child that comes in, that what we do, once we diagnose a sickle cell patient, 75% of our patients are on hydroxyurea. We place them on hydroxyurea. But the problem, the cost is there. Not all of them will continue with the hydroxyurea. When we place them on hydroxyurea, anti-malarial prevention, prophylaxis, The younger children, we encourage to have all immunization. But also immunization has its own problem. The cold chain sometimes is broken. But however, despite if you say that the child has been placed on, has had all the vaccines, but is coming down with fever, then we say yes, the child is not immunized. So we have to place the child on prophylactic antibiotics up to the age of 6. Those who are involved also, they should be more concerned about how to counsel, because you need to counsel the parents, you need to counsel the caregiver, because some, like you say, when they start the hydroxyurea, after some months, they will stop it. But the hydroxyurea will not start having its effects. It will be around 3 to 4 months before you start seeing the effects of hydroxyurea. Now we have the next slide. Now we have what we call the sickle cell team for care, which is for the care, advocacy, research, and education. It is a research group that, with coming of Adam, they encouraged us, and we said, okay, let's form a team. Gradually from 3, now we are now up to 20, involving both the states and the teaching hospital. Education is an ongoing thing, which we have to have, both for the patient, for the caregiver, for the parents, and for all of us, because we need to put all our hands on deck so that we will now move forward. How do we take care of these children? How do we take care from the children when they are going to the adults? I'm sure now, because of the care here has improved, we are seeing them going to the adulthood. But unfortunately, before they get to the adulthood, they have what we call some end organ problems, end organ failure. So by the time they're finishing their university, they've gone for youth service or during the youth service, we find that we lose them. So we need to see how we can transit them and how we can continuously give them that care. The challenges we have is the cost of hospital fee, which we are still trying to wrap up with the management to see how they can reduce it. We have some equipment that we need, some equipment that will be able to assist us to do most of the investigations. We can assess diagnosis, blood transfusion also. We need to have a group where blood will be readily available for them so that we'll be able to do transfusion. And we want to stop this end organ failure getting in the adults eventually. Thank you. Next slide. Way forward. We have to promote disease-modified agents. We have to strengthen the advocacy and community awareness. That means the data which is important. Clinic research, clinic trials will be going on. And we want to see how we can develop mentorship. Yes, I put health insurance the last, but the comma. Our health insurance system is not working well. But we need to see how we can improve the health insurance system. Especially, we don't have this community health insurance system. If we are able to have the community health insurance system, those in the community will be able to keep it. And also with that, they'll be able to get access to the health facilities and care that they have. Next slide. So thank you very much.
Next speaker after the CMD was Professor Arab, but he has sent in his apology. He's now with a bad flu, so he's not able to make it in person. However, we have our own Dr. Mala Abdul Wahab representing him. Dr. Mala, you're welcome.
In Borno, we have more than 400 health facilities across the 312 political wards. And each health facility, every week, we conduct health outreaches. All the services every day they conduct. So when you don't take care of it, that level, you cannot be able to reach the community because they are very close to the community. Almost all the urban meters are just 2 to 5 kilometers within the community. So it's trackable distance for everybody within the community. So on behalf of our boss, Professor Mohamed Arapalachi, I want to appreciate the GANSID team and all the teams that were able to make sure we have this activity here today. and we equally extend our hands of fellowship to support the cause of this activity. Thank you very much.
So moving on to our second speaker, I want to invite the president, co-founder of Borno State Sickle Cell Warrior, to come and speak on behalf of the patient.
About Borno Sickle Cell Care Foundation is, we started as a concept, as I just said. We started forming the body as an association at the first step, and then we later started conventionally through following the right channel by getting our certificate with Borno State Ministry of Poverty, Alleviation, and Youth Empowerment. From there, we started it formally as a foundation. In terms of source of funding, we don't have definite source of fund. However, contribution from our members, philanthropists, and stakeholders is the major source of income to the foundation. So our vision is to realize a supportive environment through the forming of organizational systems that will consistently and sustainably support our core and warriors, so as to bestow hope and sense of belonging to the affected individuals. And I think all what we are seeing is in line with our vision. And then the mission is to provide compassion, that is to seek help and to provide help to our less privileged sickle cell anemia warriors, and then to advocate for the care and management of sickle cell patients. And then education remains our top priority, because we have been engaged in so many educational sessions through the broadcasting media, radio stations, and even conducting programs in classes. And then in terms of prevention of sickle cell disorder, we have been engaged in so many awareness. I think we have even visited the royal father of the state, that is the Sheikh of Borno, and then we told him that we need him to be informed and then speak to the religious leaders, because they are the forefront in giving hands in marriage to the intending couples. This picture is depicting when we demanded his intervention, and then we awarded him as the patron of the association of the foundation. We have also visited the National Orientation Agency, and then we collaborated with them and seek their attention for a special advocacy for sickle cell disorder in the state. In terms of advocacy, we have, in partnership with Borno State Medical and Dental students, we have commemorated National Sickle Cell Awareness Month 2021, where we provided advocacy and free genotype testing, malaria screening, and even prescription of free drugs. For now, the major accomplishments are, we are about to launch our first magazine of the association, and then this is the cover page. This is the proposed cover page, and then we have also recently launched our website, user-friendly website that is now available at www.bsscenter.org. So I think this is so far in the past 6 to 7 years. That is what we have been doing as a patient organization. All we do is to ensure support is being rendered to those suffering with sickle cell disorder.
Thank you very much, Bashir, for that presentation. And just to say well done for all the hard work you people are doing. You have more than 1,000 registered, you have 700 on insurance scheme, you have a blood drive, support yourself during difficult times. So keep up the good work. Well done. Our next speaker is going to be Dr. Babagana Mustafa.
To share my journey as a sickle cell advocate and my inspiration, my access to community and experience in totality. So when I feel that I have to do advocacy, then I have to have the contact and I have to liaise with some of the stakeholders in Borno State. So then when I saw that Borno State has 27% of sickle cell carriers. Yobe has 32% of sickle cell carriers. And I saw that they say sickle cell disease is more common in Black nation. I say I have to do something. I'm Black facing, and people from the Western region, they are telling us that we are the ones who have sickle cell. So then I say this is our problem, and I have to do something as a human being. So before going to the local government, what I used to do, actually, I met with the stakeholders of that particular community, the chairman, the stakeholders, and some of the religious leaders. And I would collaborate I used to collaborate with the primary HTAs, workers, and also the student union and non-governmental organizations. After that, then I will move into the community for community sensitization. Then when I went to do the advocacy, I found out that most of them, they didn't even know their genotype. Then I said, I have to follow the stakeholders so that I will conduct a pre-genotype test. Then I conduct a pre-genotype test for 1,000 people. During the advocacy, then I find out accessing some of the areas is difficult. Then I have to come out with a solution. Then I sat down and talked with the registrars, senior registrars. Then I say, I have to write a book that is going to be translated into 3 languages. So then I sat down and write the body of sickle cell disease and impact of marital counseling things. So that's how I wrote my book, and then I translated it into Hausa and then Kanuri, so that the areas where I cannot access, they can read the book, and then I just did it for local people, I did it for the local people, not for the health workers. So that's how I wrote my book. And as you can see, it is in the 3 languages. And I have written how they will make it a law. So when I have given it to His Excellency, I don't know whether he has gone through it or not. Okay.
So we're going to the second half of this event. So the first half has been Maiduguri experience. We've listened to our clinicians, our patients, our advocates. So now the event is Maiduguri in collaboration with GANSID. So they've listened to what we have. So I'm going to invite, so we're going to have 2 speakers from GANSID, one Professor Adekile in person, and then Dr. Ivy online.
Thank you very much, Adama. So it's so nice to be back in Maiduguri after more than 50 years and to see the development, the vibrancy, the resilience of the people and the passion. I mean, I'm so glad. So what I'm going to do in the next 20 minutes or so is to kind of introduce you to what is GANSID all about. It is a global network from what the name suggests, including patients, patient organizations, healthcare providers, researchers, professionals, academic societies, and industry partners, okay? And any other people that are impacted by sickle cell disease and other inherited blood disorders. Now, the main mission of GANSID is to identify common purposes among inherited blood disorders and embark on cross-disease while lending its voice to disease-specific advocacy to meet the needs of people living with these disorders wherever they may be in the world. And GANSID has been bringing the voices of inherited blood disorders together to advance care, treatment, research, capacity building, and education, especially the regions of the world facing acute shortages and challenges of their healthcare systems. The vision is for a strong and united sickle cell and other inherited disorders, patient and healthcare provider communities, equipped to effectively advance disease-specific and cross-disease priorities that improve outcomes for affected families. And the mission is that through data, and I want to stress that word, data, through data-driven advocacy, collaboration, and capacity building to empower member organizations and advance cross-disease initiatives to improve outcomes for people living with sickle cell and other inherited blood disorders. So what is the strategic plan? Now, the whole idea is to work towards timely access to treatment and eventual cure for inherited blood disorders. And we outlined in the mission to continue to advance disease-specific and cross-disease advocacy at all levels, to serve as a resource hub for patient organizations that you can always reach to GANSID, for assistance. There's training, mentorship, and capacity building for patient organizations. And as we go on, we'll see how we are doing that. And then to connect patients, organizations, and clinicians worldwide. And of course, the GANSID mentorship program, and Dr. Ivy will probably talk a little more about that. But the program for now, is a 6-month program. The mentee and the mentor meet on a regular basis, either on Zoom or WhatsApp or whatever. And then at the end of the 6 months, the mentor is sponsored to travel to the site where the mentee is based and assesses the situation there, gives a lecture, and gives any other assistance that might be necessary. Next slide. How do we increase the opportunities for clinicians, patients, and industry or pharma to work together and ensure that most of our centers qualify? So we got together and we established the Clinical Trial Site Standardization Advisory Council, which I currently lead. So we're reviewing all the existing guidelines to identify the barriers and challenges that face centers in our countries from qualifying as trial centers. And eventually, before the end of the year, we're going to draft recommendation guidelines that will assist centers to know what they can do, either to collaborate with some other centers nearby or to increase their capacity by training or whatever, and let them know exactly what they have to do to qualify. Well, this is just to show you the kind of people that are working on this. We have, industry representatives, we have clinicians, and we have patient partners from across the board. I chair the board, the Advisory Council now. We have individuals or doctors from Europe, from the Americas, and as I said before, we have at least 2 individuals there who are patients, one of sickle cell disease, the other of thalassemia. There are key stakeholders in this field that we just have to work together. And when I look around today, I can see some of the key stakeholders in the sickle cell disease community or inherited blood disorders community are well represented. Okay? And that's what GANSID is all about, trying to build these kind of partnerships, all right? And that's why we have affiliate members, across the world. Okay, now I come to this pyramid. Now, this is the WHO guidance framework for sickle cell disease management in sub-Saharan Africa. And I'm happy that Dr. Mala is still with us and other members of the PHC. WHO has recognized that not just sickle cell disease, or other non-communicable diseases, we have to make provision at the lowest level, at the PHC level. Okay? Most of our patients are in the rural areas, they do not have access to secondary or tertiary care. And even if you want to see them in the secondary or tertiary center, you don't have the facilities to go, just as we saw in Katsina. Therefore, we have to build capacity at the PHC level. Now, so that the PHC level that will be the main treatment center that should be able to offer screening, counseling, and routine treatment. Okay, so this shows the hub and spoke satellite model. So we have a group of PHCs that are linked to the secondary center of first referral hospital. Okay, and the secondary center should monitor PHCs actually send doctors to work with there, what's the month or what's 2 months. And then we look at the facilities they are monitored and make sure that they are keeping to the protocols, and that they have the appropriate technology to use. So we'll be taking the final presentation on registry by Dr. Donnell Ivy.
Hello, everyone, and thank you for allowing me to present to you today as part of the Global Action Network for sickle cell disease and other inherited blood disorders. But the reason I want to thank all of you for allowing me to talk to you today is about the importance of establishing a registry. So I'll go over, a registry. Many of you have already talked about it, so of course it's going to be something you've heard before. But the importance of trying to figure out how we can all work together, as Professor Adikile said, to figure out how we can really measure where sickle cell has the greatest burden of disease. But we know that life expectancy for individuals with sickle cell disease has improved greatly. I was born in 1971, and at the time that I was born in the United States, in North Carolina, the life expectancy for a baby born with sickle cell disease in North Carolina was between 8 to 10 years. Now, due to advancements in research that we have been able to do in sickle cell disease and in the treatment of sickle cell disease, the life expectancy in the United States, in Canada, and in European countries for individuals born with sickle cell today has increased to the 50s and in some cases even the 60s. And how do we begin to improve care for individuals with sickle cell disease living in African countries, living in India, and living in other low and middle resource countries? Now, what we want to do then is look at using a registry to identify where individuals with sickle cell disease live and the level of care that they're receiving, and also to improve their access to providers that are knowledgeable about treating sickle cell disease, as well as resources that will help them to treat sickle cell disease. There is currently no global system that we have to track the number of individuals that have sickle cell disease. And we expect that individuals will continue to live a lot longer with these disorders. So it's important that we develop a registry so that we can continue to track the impact of these diseases as individuals live longer lives. In order to build this registry, though, we would have to work with partners to look at those governmental supports, look at the other strategies that exist, assess what's going on at the local level as we plan out how we implement this program to look at building the registry. It's also important that inherited blood disorders, we look at how we're able to gather this information globally to ensure that we are looking at how to address sickle cell disease in Nigeria, but also other countries that can benefit from gathering this information. So we want to make sure that we're engaging the primary health centers. We want to make sure that we're engaging the hospital, the patient organization, as well as the regulatory bodies. But we're not just here to build a registry and gather your data. There's a reason that we want to build the registry, and that's so that we can identify where those patients are and what their needs are. So we know it's not enough to just build the registry. GANSID has to also look at other programs that then begin to align resources to the needs of the patient population. And so other programs that GANSID is working on includes the GANSID mentorship program. And through the GANSID mentorship program, we hope to provide a supportive environment where members of a mentor-mentee pair, so GANSID will identify individuals that have a wealth of knowledge about how to treat sickle cell disease. Individuals like Dr. Adikule that can then be partnered with other providers that don't have that depth of knowledge yet about treating sickle cell disease, but that hope to learn. And then we can utilize the knowledge that the seasoned hematologists have to help bring along and educate the newer providers, the primary care providers, the other providers that want to play a role in treating sickle cell disease about these are the minimum standards for treating sickle cell disease. These are the steps you take for addressing sickle cell disease. So the objective of the mentorship program is to promote a continued high level of competency among healthcare providers. Teams are expected with the mentorship program to meet at least once a month for at least 1 hour during a 6-month period so that they can exchange knowledge and information, and so that would allow the mentee to grow in their understanding of how to address sickle cell disease care. We are also looking at having mentors and mentees in the same region so that African individuals in Africa that are wanting to be mentees, they can be paired with mentors in Africa that understand the environment in which they practice and that have a good wealth of knowledge about strategies they've used to address the sickle cell community in their local community. But we can't do this without you. We need you as partners in order to move all of GANSID's projects forward. We can't build the registry without your support. We can't do the WhatsApp forum without you being a part of it. We can't continue to look at strategies to improve sickle cell disease care in Nigeria unless you are a part of the effort to help us. So what we're doing right now is we're looking for sites and we're looking for patient organizations that will join GANSID in not only developing the registry, but also our other initiatives to improve sickle cell disease care. We are looking for patient organizations that will help increase awareness about our efforts among the patient population and help us with outreach. We're also looking for hospitals that will help be a part of this initiative. And with the help of all of us working together, we can build this system that would allow improved care for individuals with sickle cell disease.
With regard to the registry, I know there are a lot of other groups within the country in Nigeria that also are maintaining some registry. So I wanted to ask, how do we harmonize this? Or what do we, I mean, some center already are part of those things, collecting some, doing some registry. How does GANSID merge this, or how do they collaborate with this so that it will not be duplicate of effort?
So that's an excellent question. And part of our initial effort is going to be to look at that, what the registries are currently in Nigeria. We don't want to duplicate efforts, but what we want to try to determine is how sickle cell disease, the burden of sickle cell disease at the national level, at the regional level, so including all of Africa, and then at the global level.
Before I give, there's a question from the floor, directed to Professor Andy. We've heard a lot about sickle cell disease, but is there any active screening for other forms of hemoglobinopathies, especially in the states, in Borno State now?
We don't have any other active screening for other hemoglobinopathies. But as Prof rightly said, even the beta cell thalassemia screening it ab initio is a bit difficult. If you do that, yes, we've had some cases here where the child came with it's SS, but we found out that the father is AS, but the mother had a picture that looks like AA. On looking at that, then we said, no, 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 no. We may be dealing with thalassemia. And when we had not feel, we had to look at it and say it's most likely beta thalassemia, S thalassemia. But screening like that, ordinary screening is a bit difficult. It's not like the other, like the SS, that you would screen, do your reports, and you give you that information.
In terms of the benefit to those who are registered, I think the main benefit is care. Okay, because the earlier the child is diagnosed, clearly the better. That's one thing we have to realize. And any patient that wants to continue being treated or being cared for has to have a record and also has to be registered. I mean, it's as simple as that. I mean, we can't give them extra incentive than that, you know, but we just have to educate them in terms of the importance of regular visits to the hospital, regular, you know, being compliant with the prescriptions. Okay, so that's the main incentive.
Good afternoon. My name is Abdul Ghaffar Ibrahim from Emergency Medical. My question here is that what is the exact cause of pediatric sickle cell patient and how can it
Thank you very much. Prof just said that that's a very important question. And I just want to reiterate over and over that all these clinical questions, she has sent the list to us. We are on it. We're going to have 4 sessions every three months. And all these things are dear to your heart, put them down. What we want to have is 2-3 hour sessions where you feel free and we can interact out of the hospital, in the community, different locations. That is what we plan to do. So we address such questions because you can't start talking about priapism now and really, you know, give you the necessary response. We want it to be in an inclusive environment where you can feel free and can have all your questions answered. Is that okay? Thank you very much for that question. Any other question? Because I think we'll take 1 or 2 questions and then we'll round up.
My name is Abba Ali Ibrahim, Disease Control and Immunization, MMC. I just want to make a few contributions and clarification. My contribution is in 2020, the Nigerian Medical Student Association visited me that they want to screen young youths on sickle cell. So they said they want to screen about 100 in the Fizan community. I said Fizan and Shauri South outside, they are very close. So we're going to get 30 from me, both male and female. And then the Fizan target, we're going to give 40. After 30 minutes, when I visited them, the crowd there is almost 500, over 500. They were there seeking, they said they want to be screened. And then the fortunate thing for that screening is, one of the youths was identified as AS, one is married next week. He was asking me, what am I said, run to your wife, go on screen, go on screen for your wife. If she's also AS or SS, the chances of having SS is there. So I was expecting this will be repeated every year so that I will have more people screen. But as a student, I know it is very expensive. Even then, a screen, a test was then 1,000. And then it is very expensive for a community. And then my other issue is, in all the expertise, identifying young parents having a sickle cell child, the first time reported the hospital, there is no call for counsel there not to have more children. That issue is not being addressed. I did not hear anything about that. If there's a plan, then it is a welcome idea. Then the other issue is, if disease condition like albinos, and then the data is like HIV, are having pre-medication, and then albinos have even worked their way out to national assembly. I think sickle cell is a genetic disease. Congenital, that the children were got from their parents, which is permanent. I think, and it is very expensive. I think we're supposed to have advocates to the state government. The association has to fight more to reach the government so that a law should be passed free medication, free treatment, free schooling, and whatever. And opportunity employment should be created for them. Thank you.
Thank you very much. You can see why we needed people to be part of it. We said this is beyond clinicians. Sickle cell disease is not about just doctors, it's about everybody. The patient, the parents, the community, your neighbors. So all these are important things. So these are all valid contributions. But to respond to when you said you wanted to screen 50, 500 came out, what it means, the community are eager to be screened. But the funding is a challenge. And that is where we need influential people, people like the Honorable amongst us, to advocate for free screening. And that is why what has reduced mortality, newborn screening. And so I will hand the mic over to him and he will take it from there.
Thank you very much. In fact, let me just say the words of confidence. You know, government is just a two-way traffic. I'm a legislator among you and happen to be part of you. I'm a medical lab scientist. Before joining politics, I worked at the public hospital as a specialist officer for more than 20 years before joining politics. And then I worked in the hematology department. I know how sickle cell is devastating our children in the state and how we lost a lot of children because of non-awareness of the sickle cell cases. If you go to the village now, they may say, Iska, Karua, and all these things. The children are losing for sickle cell without being knowing what is the cause. I assure you. Now, as I said, government is two-way traffic. If any one of you, or if anybody among you, is ready to sponsor a bill concerning, so now it's a challenge for the GANSID team and the state. Not that we have a workshop or lectures today, that we are going to leave it like this. Let us be having a regular meeting like this, whether quarterly or every 6 months. So we know the situation we found ourselves in the state, more especially the northern part of the state where the high rate of illiteracy is there, but it has become no-go area as of now. We cannot reach out to the community easily because of the insurgency. But the television or radios can reach out to them. So, as I told you a day before yesterday, that let us be going to the media houses, advocating through the media to the local communities to be aware of the sickle cell and other related blood diseases. And I assure you, immediately when I go back to the house, I will start campaigning. You know, it's just like campaigning. Even a house is just made up of 28 members. You must do a thorough campaign before accepting any bill that you want to sponsor. I assure you that we are going to sponsor a bill on management and care of the sickle cell in the state. And you know, as one of the persons that spoke before me said, they were going to state specialists, they cannot come to teaching also because things were expensive in teaching also and all this is. I assure you that after that bill, we are going to harmonize the whole treatment and then the tests, both in teaching hostel and the state. You know, they have an association. Please, most of us here are civil servants or politicians. Let's see how we can sponsor or assist this as their associations of the sickle cell warriors. You know, somebody from far ground, he will die of just a little treatment. Treatment that cannot even cost more than 50,000, that child will lose his life. So, as we are here now, if we start in this sport, I think we are up to 50 or 60. If we promise that we are going to contribute only 500 naira monthly, online we are going to make an impact. We are going to assist them. Please and please, I assure you that the law will be made in the state. You know, our governor is passionate about the health, but the major problem that we are having with politicians, there are no good advisors to them. They were after what they are going to get tomorrow or today. Then to give proper health care to the public. Therefore, after making this law will come with other related matters like, as we are saying, the first thing to be done is the screening, that's the premarital screening for HIV, hepatitis, pregnancy tests, and genotype. You know, three things that I mentioned first. That's the HIV, hepatitis, and pregnancy. You know, it's related to religion even. A religion point of view, nobody will ask you to marry a pregnant woman. Nobody will ask you to marry somebody who is suffering from hepatitis or HIV, because you can get that disease and you too, you will be a victim. So the genotype one will come as a cover under age. Because the reason why initially there was a similar law that was sponsored, but the executive refused to assent it because of the religion point of view. He said that you need, you know, the pastors and I know most of the pastors were aware of all this that we are talking about, but the ulamas and the local community, they were not aware of it. They will say that these people wanted to stop the marriage in the state because even people who love each other will not get married because they will say that this person is having certain disease, this person is having certain disease. So these are some of the reasons. You know, politicians very careful. Whatever that touches politics, they don't want to do it. But the proper advocacy and enlightenment, I assure you that we are going to make a law and we are going to succeed. Thank you so much.
Thank you, Honorable. We are almost coming to the end of this program because it's meant to be 9 to 1, but I can see it becoming more and more interesting. But we have to be conscious that we have online participants and we wouldn't want to drag them beyond the time. But just to, I will give Professor Anga and Professor Adekile to give the closing remarks. But just to summarize for you people that we've made, the gains we've made. So when we made the CMD, we got the proposal for Sickle Cell Center. When the representative of the primary health care came, we heard what he said. We're going to start a lot of initiative, which has been approved. It's for us to know which areas we need to prioritize. And now what have we heard? They are going to pass a bill. Do you want to continue? Thank you. So at least we have 3 big things, you know, that we've been able to achieve. And like I said, we have big dreams. We started small, so it doesn't look small, but we thank God for everything. So I'm going to hand over to Professor Adekile and Professor Ambe to give us the closing remark. And just to say to you that the plan was for us to have lunch, but we know that the time for pay has come in. So we decided to share the lunch round so that once the remarks are made, if you want to have your lunch here, please feel free. But what we want is for people to have lunch and for us to continue to discuss. If there are issues that you were not able to raise, please feel free to wait behind. We'll be around to continue the conversation. So thank you very much. Yeah. So at the end, we want to have a photograph with the patient organization. Okay, everybody here. And so, yes, on the stage, please.
Well, I did not honestly know that this was going to be so interesting and energetic. Even the gentlemen and ladies from the PHC were supposed to leave at 10:30 or 11. I think some of them are still here. So that's really nice. So when we were planning this event, Adama and I said I just wanted to do an intimate, small, event. But as it would happen, I had to come early. I was supposed to arrive on Wednesday, have the event on Thursday, leave on Friday. But I arrived on Monday, and it's been such a wonderful opportunity. Because we met the CMD, met the Honorable, we met the Permanent Secretary. So it's been a wonderful time. And I'm so glad that I came back to Maiduguri to see so many nice people, so many passionate people who are really passionate about sickle cell disease. And I hope and pray that by the time we come back, I don't know how soon it's going to be or how late, but want to see progress on the comprehensive sickle cell center, on the bill, management and control of sickle cell disease bill, and all the other good things that we are seeing. I really want to acknowledge the sickle cell groups that are here. There's nothing we can do without you, and it's all about you. So thank you so much. So please let us continue to work together. Now, GANSID is committed to all the programs, especially the registry. We continue to talk about it, but hopefully soon it will take off. And I promise that Maiduguri will be one of the pilot centers in Nigeria. I mean, you really earned it. You have some very excellent people who are very, very passionate, and I'm also very impressed by the facilities that we have seen. So again, thank you so much, and I wish you all the very best. Thank you. Until next time.
All right. On that passionate note, I thank you all for making time to come here. And we hope to see you soon in the same venue or importantly for the same cause, that is for the sake of sickle cell disease. So thank you. So please have your lunch, hang around. Let's have the picture now and then